A harmless growth and a skin cancer can look almost identical in a photograph, so the safest answer comes from a sequence of clues, not one visual feature.
Expert host. This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. Okay, hold on. If that's really true about photographs, why can't I just use one of those consumer phone apps to check a concerning mole on my arm and just be done with it?
Well, to understand why a quick app check just isn't enough, we really have to look at what we're trying to decide here, separating a benign lesion from a malignant one. Benign simply means it's not cancer. A benign growth might get bigger over time, it might itch, it might even bleed a little if you vigorously scratch it, but it doesn't spread or invade your nearby tissue like a malignant tumor would. Malignant means cancerous. These absolutely can invade nearby tissue, and depending on the specific type, they can spread to nerves or distant organs. But here's the really interesting part. A completely harmless growth and a dangerous cancer can actually both be dark or pink or scaly or prone to bleeding.
You see, harmless growths in cancers actually share a very limited visual vocabulary. For example, a completely benign seborrheic keratosis can be really dark and crusted, making it look exactly like a melanoma or a squamous cell carcinoma. Or take a totally harmless scar. It can look remarkably like a morphiform basal cell carcinoma. Because they share so many of these visual features, a single picture or a single scan by a consumer app just isn't enough. We need a sequence.
And that brings us to the very beginning of the dermatologist detective sequence. Step 1 is history. What has the spot actually been doing? A spot that's been sitting there unchanged for 10 years tells a fundamentally different story than a red nodule that just popped up last month. Step 2 is symptoms and change. Is its behavior coherent? Like, does it bleed spontaneously without any trauma at all? And step 3 is the whole patient context. We have to look at your individual baseline risk. Things like your sun exposure, family history, age, immune status. The exact same looking spot carries an entirely different meaning on two different patients. Your risk doesn't magically diagnose the spot, but it definitely changes our threshold for taking action.
Next up, we examine the spot in really good light and compare it to the rest of your skin. We call this the ugly duckling principle. We're basically looking to see if this specific spot departs from your usual pattern. A mole that looks perfectly ordinary on someone else might be a striking, highly concerning outlier on you.
Okay, but what happens if a spot visually fits right in? Like it looks completely normal compared to my other skin, but it physically feels weird or hard.
And that right there is exactly why we move to palpation, which is examining the spot by touch. This step is absolutely critical because a standard photograph cannot show you if a visually flat spot is actually firm or what we call indurated underneath the surface. Touch reveals whether a nodule feels tethered to deeper tissue. It gives us firmness, depth, and tenderness, details that a camera simply cannot capture.
So wait, we've looked at the history, we've compared it to the rest of the skin, and we've physically felt the spot. But do we know for absolutely sure it's not cancer yet? Like, is zooming in with magnification enough to finally prove it?
Not necessarily. And that brings us to dermoscopy, which is the next tool we use to narrow down that uncertainty. A dermatoscope is this handheld lighted magnifier that actually reduces surface reflection. It lets us see subsurface pigment, blood vessel structures, and keratin patterns that your naked eye would entirely miss. It significantly improves diagnostic accuracy in trained hands. But, and this is an absolutely crucial point, it is not a microscope for living tissue. It does not produce a final pathology diagnosis. Let's actually look at the numbers behind this. In studies of expert use, dermoscopy improves sensitivity for diagnosing melanoma to between 76 and 92% at a fixed 80% specificity. Now, those are really strong numbers, and they definitely show how vital this tool is in the clinic, but they aren't 100%. Dermoscopy does not replace a tissue diagnosis when important uncertainty still remains about a lesion.
Okay, but if we're still not completely sure after all that, can't we just, keep an eye on it over time and see what it does?
Only under some very strict conditions. Monitoring isn't just a casual, let's wait and see approach. It's a strict diagnostic plan. It requires a baseline standardized photograph, a defined short-interval monitoring period, a reliable return visit from the patient, and an explicit trigger for a biopsy. It completely fails if the patient can't reliably return to the clinic, or if the lesion is already just too concerning to watch safely.
The context for this is absolutely vital. One specialty clinic study that used sequential digital dermoscopy over a 3-month interval found that 99.2% of unchanged flat lesions were actually benign. But remember,
This finding only justifies watching carefully selected mildly atypical flat lesions. It is never the safe path for a nodular, rapidly changing, painful, or spontaneously bleeding lesion.
This sequence also perfectly explains the limits of consumer photo tools and teledermatology. They are fantastic for assisting with initial triage and really improving access to care. But they cannot palpate a lesion, they completely lack that whole skin comparison we just talked about, they can't guarantee image quality beyond whatever you submit, and ultimately, they cannot safely rule out cancer on their own. They simply do not replace a real clinical relationship.
So, when our clinical observation reaches its limit, and that remaining bit of uncertainty could actually affect your safety or your treatment plan, we have to move from a clinical diagnosis, which is our best assessment based on the story, exam, and magnification, to a tissue diagnosis. Think of them as partners, not competitors.
So this is where we actually look at the cells, right?
Exactly. We achieve that through a biopsy and dermatology pathology. A biopsy basically involves removing part or all of a lesion so it can be examined microscopically by a pathologist who is specifically focused on skin disease. The tissue sample taken has to be deep enough and broad enough to answer the specific medical question being asked by the clinician.
A biopsy becomes the necessary and decisive step in a few very strict scenarios, when cancer just cannot be excluded safely, when the lesion is changing or symptomatic, or when having the actual tissue type, depth, or growth pattern will determine your treatment plan. You absolutely do not substitute prolonged monitoring or repeated low-quality phone photos when these specific triggers are met.
So the lab report isn't always the final, unquestionable word?
Exactly right. The sequence does not end just because a lab report prints out. The clinician must perform what's called clinical pathologic correlation. This simply means asking, does the microscopic lab result actually match what the lesion looked and felt like back in the clinic? Because a biopsy sample's only a portion of a lesion, we have to reconcile that pathology result with the original clinical impression. We do this to ensure the sample didn't miss a more aggressive component hiding elsewhere in a mixed tumor.
Okay, let's bring this to life with two quick cases to see how this sequence works in the real world. Case 1. A waxy ground growth appears on a patient. Step 2. It gets scratched, maybe by accident, and becomes heavily crusted, making it look a bit alarming. Step 3. The patient's history and a classic magnified dermoscopic pattern perfectly match an irritated seborrheic keratosis. Because the story and the visual pattern cohere perfectly, this safely leads to reassurance for the patient without needing any surgery or biopsy.
Now contrast that entirely with case 2. A small pink bump appears. It might look completely ordinary, maybe even harmless in a quick phone photograph. But step 2, palpation in the clinic reveals it feels unusually firm, and the patient's history shows it bleeds repeatedly without any trauma. That benign visual appearance is completely overridden by the firmness and the symptoms. Step 3, a biopsy is performed and it confirms basal cell carcinoma. This proves exactly why a biopsy supplies the ground truth that appearance alone could not.
All right, so bringing this all together, what should viewers actually do next if they find a spot they're genuinely worried about? The actionable next steps are very straightforward. You need to seek prompt in-person evaluation for spots that are new, rapidly changing, painful, spontaneously bleeding, ulcerated, firm, or fixed. If you have a concerning spot, do not rely solely on an image to decide if it is safe. Get it evaluated in person.
I invite you to read the complete Skin Trust article to explore this diagnostic sequence further, and please, always discuss your individual decisions with your treating clinician. Dr. Hocker created Skin Trust to provide free evidence-based dermatology education and help patients and clinicians make clearer decisions together. If you're wondering what happens next if a biopsy does actually show cancer, check out our explainer on what are the treatment options for basal cell carcinoma. Until then, ask yourself, if a camera can't feel a spot, what else might it be missing?